Our hospitals are operating at close to 100% capacity. We hear phrases like ambulance ramping, bed block, patient flow, and we've kind of normalised it. Older adults make up the majority of occupied hospital beds. And here's the reality. Hospitals can be the worst possible place for an older person. They lose strength, they accelerate frailty, and the longer they stay, the less likely they're going to return home. So if we know that, why is our system still built around crisis? I'm Hannah McQueen, and in this bite-sized episode, I'm joined by Dr. Cheryl Johnson, lead geriatrician at Brightly, to discuss the real cost of hospital for seniors. Cheryl, you've been working in the healthcare system for decades. You know how things are funded, the financial implications of different decisions. Is our healthcare system set up to treat crisis or to prevent it?
Yeah, let's not say decades, let's say about over 20 years.
Well, I'm no English major, but it feels like decades.
Yep.
But yeah.
But, you know, we talk a lot about our health system being really stretched, and we talk about our health system being very reactive. And unfortunately, it is quite reactive, that we focus on when people get disease rather than focusing on prevention, because that's how our hospitals are set up. People come into the emergency department with an issue that we manage, and hopefully we turn them out and get them out of hospital. And it's not, the mechanisms to be able to do more preventative health are challenging.
In the healthcare system?
Within our healthcare system, yeah. We can do it a little bit, and certainly as a geriatrician, I would try and do as much preventative care as I can when I look at a person and do that comprehensive assessment and trying to think about what their risks are. But often, you know, it's a bit too late. Those risks are already there, or they're already progressing. And because we're not seeing them early enough, or we just don't have the mechanisms to have that preventative care. Because
by and large, you are seeing them in the public system, so the average age is about 85, so it's pretty hard to walk back a few things at that age. Yeah. We really needed to start earlier. And that probably isn't, although the healthcare system would benefit from us being prevention focused, that probably is a move back to the individual to take responsibility for that. Would that be fair?
Yeah, I think you're right about that. And, you know, people, or, you know, our own clients at Brightly, trying to take ownership of their healthcare and really understanding it. And it's our job to empower people to understand what's happening to their health and also what might happen. You know, a lot of us don't really want to know sometimes about what's happening to our health, and you know, a lot of people don't really want to know what happens in those doors, you know, behind the doors of the hospital. But it is really important for us to know where our health is at, you know, even if in your 20s, your 30s, your 40s, and beyond that, into your 50s and 60s and decades after that. It's really important to understand where your health is now. What can you do to improve your health and improve your longevity and stave off some of those diseases of aging?
What does success look like in a hospital system? I'm always curious as to what their KPIs are. Like, is it bed turnover? Is it efficiency of staff? I look at things through a commercial lens, and I look at that and I think, this doesn't feel commercial.
Yeah. We do have a lot of KPIs in the hospital, but they tend to be things like length of stay. So how long is a person staying? We also look at those who stay more than 3 weeks, more than 21 days. We look at readmissions. So, you know, that would be if someone has been in hospital and then they come back into hospital within a time frame, and that's usually, you know, 28 days or a month. We look at mortality, because obviously we're trying to stop people from dying. Doesn't always happen. So they're the kind of things that each individual service would be looking at. We obviously look at volumes and the volumes and throughputs and things like that. But what does success look like? I mean, that's a really hard question to answer, but I think success, when we think about older people, success would look like moving a lot of their care into the community. Hospitals, as we've said, can be really dangerous places for older people. So it's about taking them out of that hospital and trying to manage them where they're best, in their own home and in their own familiar environment, surrounded by the people that love them. So a lot of what we're looking at within the hospital is shifting to a community focus and what we can provide out there and all those beds out there, because there's not enough hospital beds either now or that we're creating in the future to be able to manage what we're going to have to manage.
Yeah, because if we think of the fact that one of the reasons why we have this bed block, which is filled with older people predominantly, is because there isn't a place for them to go to next, because it's been deemed unsafe for them to return home. So they're kind of languishing in hospital, probably don't even want to be there while they wait for a rest home to become available. But we've just heard that we're kind of 12,000 rest home beds short. Well, that means that the hospitals are going to be fuller again, isn't it? And so we really need to try and do more. And the onus is on us and on families to empower them to do more, because a lot of us are just flapping around and don't actually know what we're supposed to be doing to be helpful. But we know we don't want our parents in hospital. But you've seen thousands of admissions into hospital in your decades of of incredible work that you do. You must see instances where you've said to yourself, or have you had instances where you've said to yourself, this didn't need to happen, that these people didn't need to be here if we had got to them earlier?
Yeah, absolutely. And, we've talked a lot about that sort of preventative care. And I think there's a few things to pick up there, but there's the thing about, knowledge, and knowledge is power. And yes, it's a bit trite to say, but actually understanding what's happening to you or understanding what's happening to your loved one is really important to be able to navigate what might happen in the future. If I think about my work within the hospital system, a really common thing that happens that I do see a lot is I work on a rehabilitation ward or a rehab ward. And a rehabilitation ward is a place where we take all the people in the acute wards who have, so they're older adults, they've had lots of things happen to them. They've had infections, they might have fallen, they might have broken something, they might have had a stroke, they might have had whatever. We take all them into our ward because they're weak, because they're not walking well, and we try to get them better, and we try to get them back on their feet, and we try to get them out of hospital and hopefully back to their own homes. It's not uncommon that I will have a conversation with a family member and they'll go, we just want one more week in hospital. And I'm like, no, please, no, because I know what's going to happen in that week and I can predict it. And I can say, you're going to get an infection. The person next door to them, their lovely visitor's going to come in and bring flu because it's the middle of winter. You're going to spend that week with a chest infection, with influenza or something else going on, and that's wasted time. And you're going to be worse off that week later because you've had more deconditioning, more of that muscle loss, and more functional impairment or more difficulty doing your activities that you need to do during the day. For what benefit?
Probably they're motivated by respite, or they think it's safer for the parent to be there. They don't appreciate that actually the risks start to bank in the other direction.
Absolutely, and it's about having that really honest conversation and understanding what's motivating the family member to say we need one more week, and trying to understand what that is. And maybe that's because they're going away, or maybe they're having, renovations or whatever it is. Something's happening at home, and trying to understand what that is that's preventing that person from going home, or where their fears are, where their worries are, and trying to work together to get that person out.
You said that it would be helpful if people could take note of the changes in their body before it becomes a point of crisis. When I've spoken to my mum about the changes in her body, because she would say things are changing, her sleep's definitely changing, her appetite's changing, she's had some near falls, and if I put the falls to one side, she would put it all down to aging. This is just aging. And they definitely don't want to catastrophize anything, so they accept that it's just aging. So we're kind of up against a system that it's helpful for people to be dismissive of these things because we don't even have beds for them anyway, so just think it's aging.
Yeah.
But if we were going to try and be proactive, what are some symptoms that would be really helpful to be on the lookout for, because that indicates this isn't just aging, this is something that is bigger than what you think, and most likely treatable in some way if we get to it earlier? Because I think some people don't want to know that it's something big because you just don't want to know.
Yep.
And
ignorance is bliss.
Ignorance is bliss. You don't want to be confronted with something, but they don't realise that so many of these things, if we can get to them early enough, some of them can be reversed, which I thought was incredible because that's the exact opposite of aging. Some can be slowed, which feels like you're still in control, and everything else that you're putting down to aging can just be better managed. That feels good.
Yep.
But what are those little bits that we should be on the lookout for in either our own bodies or in our parents' bodies?
Yeah, there's a lot to unpack there. Things that we would look at in our Brightly assessment, I guess, speaks to some of that. So some of the things we're looking for is frailty. Are you having difficulty getting out of a chair? Are you sort of feeling tired and exhausted? You know, are you noticing any changes with your memory and being a bit more forgetful, or things are a bit more difficult than they used to be? Have you got pain? You know, pain's a really common symptom that people have and often can signify some other underlying disease. So all of those things that we're looking at in that whole of person assessment can help us pinpoint areas, as you say, where we can either treat it and get it better and improve it, or can we manage it, or can we stop things from progressing? And so there is a lot that we can do, and people will just say, oh well, I'm getting older, and it's like there's a whole branch of medicine here that is devoted to looking after older people because there is so much to do and so much value that we can add.
And I guess if the symptom, the objective symptom, is common to a lot of people, we incorrectly conclude that the cause of that symptom must be the same for everyone, where there could be completely unrelated reasons between you and your friend as to why neither of you are sleeping.
Yeah.
And so the response has to be tailored, 100% tailored to your situation. It is no one size fits all as we get to that point, right? Because people say to me, well, what's a hack or something? Like my mum says, you know, for her brain health. She's like, well, I do Wordles. And I'm like, well, I'm pretty sure that just makes you good at crosswords or something. I'm not convinced it does much else. But I'm not the clinician. Who would I know? But what would I know? But they have these little hacks that they think, oh, it's going to make a difference. And it's like, no, this isn't the time for us to be hacking. This is the time for us to be thoughtful and precise.
Yeah.
But is this just Dr. McQueen coming out at the moment? Is there actually clinical backing for this?
Yeah, absolutely. And it's often the sum of its parts, and you can do, you know, a little something in every domain or something in every part of your life to improve things. And as we said before, it's just that knowledge and understanding what's happening to you or what's happening to your loved one, and then we can tailor those interventions. Unfortunately, we know that while hacks are great, you actually have to put the mahi in. You've actually got to do the work.
Yes.
You've got to do the exercise. You've got to, look after your brain. You've got to take your medications, provided they've been well reviewed and are appropriate for you. you've got to try and get your sleep hygiene as good as you can, and have those routines for sleep, and have all your conditions managed as best you can, and preventative health, and screening for cancers, and all of those other things that we've talked about.
So that feels like there's some personal responsibility there, back to the individual, back to the families, to help those behaviours.
Right. Absolutely, yeah. And I think it's also about control, and it's about understanding what's happening to you, and agency. Saying, I understand my health really well. I know what might happen. Yeah, it's a bit scary. Yeah, we use terms like the D word, like dementia, or we use cognitive impairment, and we might talk about fractures, and we talk about institutionalization, and all these other words that aren't nice. But it's about that agency and understanding, if I do something now, I'm going to stop that happening in the future.
Mm-hmm. If someone wanted to reduce their hospital risk by 20% in the next year, give us 3 hacks.
I love it, by 20%. Okay. I think it's all that kind of stuff that we've talked about. It's about preventative medicine, getting your vaccines, getting all your cancer screening, understanding what your cardiovascular risk profile is, your cholesterol, your blood pressure, diabetes risk, smoking, all of that stuff. Get all that under control and managed, and making sure you're getting your annual flu vaccinations and things. Understanding your medical conditions, so understanding what diseases you have, making sure you're on the right medications, and that you keep taking those medications. And then thinking more about the future, and thinking about how you mitigate other risk like falls and dementia. And that comes down to things like exercise, social interactions, hearing, all of those things that are really important to prevent.
If we didn't invest in our own preventative care, and we just kind of kept drifting towards ageing, and we all did it, what does that mean for the hospital system, the healthcare system, in the next 10 years?
Well, the hospital's always going to be open. We are open 24/7, and we will always have, patients coming in. But what I'd like to see is that we have that, the patients come into hospital, they get assessed quickly, we turn them around and we get them back out in the community. We manage their conditions well in the community with the support of the hospital and the GP, all of us triangulating together. We have a really strong primary care GP service that can be responsive to any changes that are happening, and being able to have access to specialist care, and that flow between us, the specialists, and the GP, and us all working together for that person. And I think is that
what you want to see? Because that's certainly not what people are experiencing.
No, that's what I'd like to see.
Okay, yeah. So if things left unchecked, that's the dream state. But if that actually requires someone to do something to make that happen.
I like living in the dream state. It's a nice place to live.
I know, but I'm the daughter. If we do nothing, if we don't invest in our own health, can the healthcare system cope with it? We already have ambulances backing up.
Yep.
My son went into the emergency department. We waited for 6 hours in an ambulance. We couldn't even get into the emergency department. So, and then he discharged himself anyway. I'm like, what? So, isn't it just going to get worse if we don't do something? And then there are people who really need to be in that hospital who aren't getting the care because these beds are full, and they shouldn't be. I mean, this is a friend of a friend, not someone I know directly. She was pregnant and needed to go into hospital to have her baby, and she was shooed away. We don't have beds to come back. And this is maternity, so this isn't even kind of linked directly. Well, they might have borrowed a bed for, I don't know.
Possibly, but not my area of expertise.
No. Yeah. And she came back a couple of days later. They said, look, we still don't have beds, come back again. And she needed to be induced. I mean, I'm no doctor, but when you're
it
was cooked. It was like 10 or something days overdue. Her baby died. Like, there are real implications if we don't start doing something different. Would you agree?
Yeah, absolutely. If we don't change, we're just going to continue to get what we're going to get, you know,
Worse.
and it's going to get worse. And we know that people are aging. We know that, you know, the baby boomers are increasing, and you know, we've talked about the silver tsunami or the grey tsunami that's coming. We do need to change things. We do need to have much more proactive care. And we, as I said, you know, that state of moving people into the community to look after them. I think the hospitals understand that, because we have been working on community models about, you know, having the care in the community and saying, okay, you're well enough to leave hospital now, and we can treat you where you are. I think one of the other things I haven't said when it comes to that, you know, having a loved one in hospital, is getting your head around that the person's not going to be better when they leave hospital. They're not going to be back to normal. They're going to be well enough to get better at home, because that is the environment that is better for them. And so a lot of conversations that I'll have with people is, well, mum's not better. I'm like, yep, that's fine. She's going to get better a lot quicker when she's back in her own home, in her own environment, doing a lot more activity, because there's no lovely tea lady bringing her morning coffee or her morning cup of tea. She's going to have to do all that herself. That's far better for her. So it's just kind of getting our mindset that hospitals need to be for the when you're really sick, and then shifting everything out to the community. And that's what we're focusing on, particularly in lots of areas of New Zealand at the moment. We're focusing on that kind of care.
Okay. Dr. Cheryl Johnson, thank you for joining us.
Thanks, Anna. Nice to see you again.
Hospitals will always have a role, but they were never meant to be the default destination for ageing. If we keep building a system that waits for collapse, we'll keep managing decline. If we build a system that detects drift early, coordinates expertise, and supports behavioural change, we can change outcomes. At Brightly, we're focused on understanding your baseline, identifying your risks, and acting before hospital becomes the next step. Because ageing well shouldn't depend on surviving a crisis. It should depend on never needing one. If you want to learn more about how to stay out of hospital as you age, listen to the full-length episode before this one. I'll see you next time on the next bit.